So, good evening, everybody, and welcome to another episode of the National Fellow Online Lecture Series. This particular series is sponsored by American Medical Society of Sports Medicine Fellow Online Education Subcommittee, the Education Committee, as well as the Fellowship Committee. It's with great excitement that I present to you Dr. Fredericson, who will be speaking on bone stress injuries, diagnosis, treatment, and prevention. Just stay tuned for upcoming lecture next week. We have Dr. Craig Rudy, who's going to be presenting on upper extremity trauma, and that session will be moderated by Sam Mazel. Um, as a member of the AMSSM ultrasound committee and subcommittees, we've had this project going on for a while, which is the Library of Sports Ultrasound Pathologies. Two of my colleagues, Dr. Diamarco and Dr. Kirsten Schwartz, are both involved in this. The whole idea is for trainees as well as attending physicians to submit sports ultrasound pathologies that are rare and not as common. After the submission and review and approval of this pathology ultrasound pictures, it will be published at AMSSM website. And you can also actually use this as a publication on your CV. A couple of housekeeping rules before we get started. Remember, this serves as an adjunct to your individual's program's education programming. It provides fellows with direct access to education experience with experienced AMSSM members and sometimes invited speakers in a variety of formats. And lastly, but not the least, it assists in CAQ exam preparations. Please remember to put your device microphone on mute and turn the video off. Submit the questions that you might have during the course of the talk. And preferably, if you can, include your name and the program that you are. And as the moderator, I will ask the question after Dr. Fredericson is done with his talk. If you have any questions or concerns about the talk, feel free to reach out to myself or any of the Dr. Laura Goldberg, who are the co-chairs of this Fellowship Online talk. So I want to bring it back to a speaker, Dr. Fredericson. I will try to read a short and succinct version of his well-illustrious career so far. Dr. Fredericson is the first physician promoted to professor of physical medicine and rehabilitation at Stanford University and is currently director of PM&R Sports Medicine in the Department of Orthopedic Surgery, is the co-director of Stanford Longevity Center and the founder of Lifestyle Medicine. He is also the head team physician for Stanford Track and Field and Swimming Team, as well as the WUSI Human Performance Alliance member. In addition, he has volunteered extensively at both national and international levels with U.S. Track and Field and International Olympic Committees. He has been featured and spoken numerous national and international sports medicine and rehabilitation symposiums and as visiting professor. He has published over 245 peer-reviewed articles, 43 book chapters, and 5 books focused on improvements, treatments, and prevention of strategies and overuse injuries in athletes. One of the key things that I want to highlight before I pass the stage to him is his work impact is widely recognized. He's listed on ResearchGate as one of the top cited researchers, 99th percentile, with about 3,500, with about 13,500 citations of his work. So I'll stop at that. I really appreciate you giving this talk today, Dr. Fredericson.
So yeah, I appreciate everybody taking time out of your day, evening. Hopefully this will be informative. So spent a lot of my career dealing with track and field athletes, and bone stress injuries is certainly one of the most common injuries we see. So the objective today, my main goal is to give you a systematic approach to not only diagnosing and treating bone stress injuries, but really more importantly, how do you guide return to play? I'm also going to, depending on how much time we have, just go over some strategies for BSI prevention. That's something that I've really focused on the past 10 to 15 years. So most of you know that bone stress injuries are exceedingly common. Up to 20% of all injuries in sports and military populations. Now, if you're dealing with track and field athletes, we looked at this in our Stanford and UCLA athletes as part of a study we did back in 2010 to 2013. And while 20% of all runners did sustain one or more bone stress injuries, up to 35% of females, and at one point it was up to 38% of our Stanford females sustained a bone stress injury every year. So as you can imagine, it was pretty devastating to a lot of these athletes. The basic definition is bone stress injury is the failure of the skeleton to withstand submaximal forces acting over time. So these are overuse injuries, right? Which means that if we can catch them early, they're not as devastating. This is just looking at one slide. We won't get into a lot of detail on it, but this is looking at what happens at the microscopic level. And essentially, you start off with these microfractures in the bone, and that's what we're going to see on MRI as marrow edema. Eventually, if the body cannot keep up, then these microfractures eventually develop into a full-blown cortical fracture. There are a lot of risk factors, from altered gait mechanics, increased training loads, impact forces, bone health. Uh, Invariably, it'll be more than one of these. But more often than not, there is some type of overuse injury history, even in our elite athletes, at Stanford or with USA Track and Field. Now, this is an actual case. We put on the Stanford Track and Field Invitational every year, and this was a high school runner. Wasn't the actual picture, but this is her actual X-ray. But it pretty much went down like this. She was just running around the track. All of a sudden, she just collapses. Nobody really hit her. There wasn't anything obvious that caused it. And you look at that fracture, you're like, oh my gosh, that's like serious trauma, right? But she just collapsed. Like nobody hit her, or she didn't fall awkwardly per se. She may have stumbled a little bit. So you have to say, what the heck is going on here, right? So now we have to define these terms. So we used to talk about a fatigue fracture, and that would be what we would define as a bone stress injury or stress fracture. So you have normal bone with abnormal forces. And we used to talk about insufficiency fractures more in sort of our older population, particularly older women who have low bone density, and with sustained fractures with relatively normal forces. Unfortunately, we realized that many of our young athletes, particularly our young women, fall into this insufficiency category. And if you look at their bone mineral density, about 50% of elite women distance runners have low bone density. So that's a huge risk factor. Now we can go into why that happens and how to prevent it. We'll address some of that if we have time. But when you're dealing with this osteoporotic bone, that's quite a challenge. So you all are aware of the female athlete triad, low energy availability, plus or minus a frank eating disorder, low bone mineral density, and menstrual dysfunction. But you can see the same thing in males. The only difference is that now, instead of menstrual dysfunction, we're talking about hypogonadotrophic hypogonadism. And we've published on this, and we've actually put out two consensus statements, one defining the scientific basis of the male athlete triad, and then also guidelines in terms of treatment and return to play. So it's real, it exists. It's not as obvious in the females, but it is something to keep in mind. This is from the 2014 Female Athlete Triad Coalition Consensus Statement. And I'm actually the current president now, and we're coming out in the next couple of months. The paper's been accepted revised consensus statements that are going to be really packed full with tons of good information. But this is still really helpful. So when an athlete comes in, let's say your pre-participation physical, you can go through this. Do they have low energy availability? What's their BMI? History of delayed menarche, oligamenorrhea or amenorrhea. Um, if you have the opportunity to check their bone density, that can be helpful, but the score is still useful even if you don't have that score. And then do they have any previous history of stress reactions, stress fracture, or what we call bone stress injury? And based on that, you can then give them different points. And based on those points, um, you can then determine, are they full clearance? Are they provisional or limited, or are they restricted? So this can be, again, extremely helpful, targeting who are the high-risk athletes, and then really who should you put your emphasis on in terms of prevention. I just wanted to point out that we've done this both for the female as well as the male athlete triad. And even if you take out some of the questions that are specific for the females, it still can be a very helpful risk assessment tool. So the first thing, again, we talked about now is, do they have any history of triad or red-esque? And you need to keep that in mind, because if they do, that's certainly going to impede healing. Then the next thing is, what is the grade of the bone stress injury? And there's a continuum from a silent stress reaction to a symptomatic to a full-blown stress fracture. And we define a stress reaction or a stress response with periosteal and or marrow edema, but there's no fracture line at this point. A stress fracture is obviously, now you start to see an actual break in the cortex, but you still will continue to see, in most cases, this periosteal edema as well as the marrow edema, in addition to the fracture line. That's why, to me, it's pretty clear that this is a continuum of injury. And this is a grading system I came up with years ago for these injuries in the tibia. And essentially, first stage is just the periosteal edema. Now, you might call that like mediotibial stress syndrome or shin splints. Grade 2 is where you'll start to see on your T2-weighted fat suppressed images, you'll see not only the periosteal, but marrow edema. Grade 3, now you'll see it on T1 as well as T2. And grade 4 is where you start to see these cortical changes. Other people have looked at this and taken this grading system just to see if it applies to all stress injuries, and essentially it held up quite well. The only difference is that for that grade 1, and I defined it as pure periosteal edema. In other bones, it may manifest more as just very mild marrow edema along with the periosteal edema. But otherwise, this grading system can really be quite helpful. Now, one way it can be helpful is it can really help you determine the timeline for return to sport. And this is a study by my colleague at this is Elizabeth Arnett at University of Minnesota. And she published on length of recovery and MRI grade. So you can see there's a real difference between our grade 3 and 4 injuries, what we call high-grade bone stress injuries, versus our lower grades, the 1 and 2. If you have a grade 3, it's going to take upwards of 12 weeks, a grade 4, upwards of 16 weeks. Now, that's not every injury is going to take that long, but it just gives you an idea that the higher the grade, the longer it's going to take to heal. Keep in mind, though, that just because you see something on the MRI doesn't mean that it's clinically significant. This is a study that I did on our incoming freshman cross-country runners one year. We got MRIs on all of their tibias. They were all asymptomatic, and almost 50% of them had marrow edema. But again, none of them were symptomatic. And it did not correlate with who went on to develop a symptomatic bone stress injury. So again, when you get an MRI, you're going to see a lot, make sure it correlates clinically. Particularly if, let's say, you get an MRI in the feet, you get an MRI on a runner's foot, and you're going to see all kinds of stress response, but it may not really matter much clinically. Now, the third thing to think about is, are you dealing with what we call trabecular rich or cortical rich bone? So trabecular rich bone would be, for instance, the femoral neck, the sacrum, pelvis, even the calcaneus. And trabecular rich bone has a greater surface area. It's more impacted by metabolic bone disease, such as that you might see with an energy deficit or a low estrogen or testosterone state. Cortical rich bone is generally more susceptible to impact or shearing biomechanical forces. So your long bones like the tibia, fibula, the femoral shaft, metatarsals. Uh, we found in a side light from one of our bigger studies we call the Healthy Runner Project that the athletes who had higher triad risk scores, so on that cumulative risk assessment tool that we talked about, the higher your scores, the increased risk you were for a trabecular bone stress injury. So a high triad risk score, those who had a higher triad risk score had a significantly higher incidence of a trabecular-rich bone stress injury than women with a low triad risk. And each 1 point increase in that triad risk score was associated with a 26% increased risk of developing a trabecular-rich bone stress injury. And this is from UCLA and Dr. Nativ, really Nativ, a good colleague of mine. And she broke this down again in terms of return to play. And it's pretty clear that if you have a bone stress injury in trabecular rich bone, and we say trabecular rich because all bone has some trabecular and cortical bone, but we're talking about bones that are predominantly trabecular bone. So if you have a bone stress injury, let's say in your pelvis, it's going to take longer typically than, let's say, in your tibia, more of the long bone and more impacted by more shear forces. And the fourth thing to think about now is it in what I call a high risk or a low risk location? So high risk bone stress injuries would be any of these here. I won't list them all. And the reason we call them high risk is that these are fractures that are predominantly loaded in tension and or they have poor vascularity and there's serious sequelae from undertreatment. So for instance, the navicular would be a great example of that, where you have these fractures typically in that watershed area where there's poor blood supply. If it is in a high risk location, typically it's going to require immediate non-weight bearing, and you may even consider surgical intervention to allow earlier return to play or prevent refracture or something more catastrophic. So just, yeah. And for these, you really do want radiographic evidence of healing before you get them back to running on the ground. Now, if you're dealing with a more low-risk bone stress injury, so the typical posterior medial injury in the tibia or the fibula, calcaneus, or the distal metatarsals, now these fractures are predominantly loaded in compression. So if you look at the tibia, that posterior medial side, that's the compressive side of the bone. The lateral and anterior part of the bone is the tension side. That's why a fracture there becomes more high risk. And with a low risk bone stress injury, your decision to restrict or modify their activity can really be based on symptoms. You don't have to be as reliant on the imaging per se before you get them back to activity. And typically we'll modify their activity to a pain-free level. We may immobilize them, but typically not fully non-weight bearing, but just enough to unload the bone so they can get around without pain. And with these, once the athlete is pain-free and the site is at least relatively non-tender. They may still have some pain, but as long as they're pain-free with their activities, now you can start some progressive strengthening, look at their technique, gait evaluation, and do a graded impact loading progression. Now, sometimes you'll come across a case in season. And if it's in a low risk bone, I would never do this. And if it was in a high risk area, but if it's a low risk, then you can have a discussion with the athlete on the risks and benefits of continued participation. A lot of times with these, let's say it's posterior medial tibia, particularly if it's, let's say, maybe a middle distance runner, they're not putting in so much of the high mileage. I'll let them do their interval work, for their longer runs that maybe they can get in the pool or alter G, the anti-gravity treadmill. And so we've been able to do this with some athletes, as long as you continue to watch them closely and get them through the season. As long as, there's a shared decision making about the potential risks here. This is what I call the medium risk. So they're not, the high risk where you're immediate non-weight bearing and there's potential for surgery, but they're not low risk either. So I'm not going to let them participate during the season, even in a modified way. But this would be the pelvis. So the sacrum, some people would put the sacrum in a high risk category, but it's pretty rare that these would go on to surgery. Femoral shaft, proximal tibia, so not this is typical sort of mid-distal tibia, but more proximal, cuboid or cuneiform, or even the calcaneus. So putting this all together, and this is something we just published, you put together all of those four things we talked about. So what is their cumulative risk assessment? So, triad risk factors or red S. What's the bone location? So is it in a high risk, medium, or low risk area? What's the MRI grade? And then what's the bone type? Is it cortical or trabecular bone? And you can sort of come up with, based on the points, then have a better idea of how long it's going to take for return to play. So just as an example, for each additional point on that scale, once you add up the points, is associated with increased time for return to run. So for each additional risk, we found that it took 8.4 days longer for women and 4.7 days longer for men. I don't have a good explanation in terms of why the women took longer than men, possibly because they had higher risk assessment scores, triad risk assessment. So let's go over some of the examples here. I'm going to cover mainly the high risk injuries because I think those are the most challenging for you, particularly I know a lot of you are still in training. So the sacrum, unfortunately, is one of our more common injuries that we see with our distance runners. And these will fool you. They're going to often present with just this vague buttock or low back pain. You may think it's like a sacroiliitis. But be careful because really the last thing you want to do is any kind of high velocity manipulation here. You certainly wouldn't want to inject this with corticosteroid. But you're often going to see this, not always, but often in females with low bone density. So this is basically intrabecular bone, which is the same as cancellous bone. So the Hospital for Special Surgery actually published on this based on what they saw in their women's sports medicine clinic. And based on what they were seeing is the women who came in with a stress fracture or bone stress injury, and keep in mind throughout this talk, the term stress fracture and bone stress injury may go back and forth because some of this work is based on before we were using the term bone stress injury, but consider it the same for the purposes. Bone stress injury is just more talking about the continuum of injury. But basically, if you had a stress injury in trabecular bone, they said it justifies a workup for osteoporosis. This is a case study, a case series I published a number of years ago. Certainly seen a lot more of these injuries since then. But this was 21 runners who had a sacral stress fracture. 12 were females. 9 of them had a history of amenorrhea, and 7 of them met criteria for full-blown osteopenia, and 2 with osteoporosis. And even 2 of the men had osteopenia, which is not actually uncommon in a lot of these male distance runners. Another one that's pretty common is in the pubic rami. This used to be really common in the military. They'll typically present with groin pain. And it was interesting because in the military, when they started to see a lot of this was right when the women were starting to enter the military and they were training with the men. And they had them march at the same uh, rate or stride length as the men. And most of them were overstriding, and they felt that this was a big risk factor as to why that happened. Now, again, though, a lot of these athletes are also going to have low bone density. Now, when the military went and had the women adjust more to their normal stride length, they did see a decreased incidence in this injury. As we go down to the femur, the biggest one, obviously, that you don't want to miss is in the femoral neck. Now, fortunately, in most athletes, when you see this injury, it's going to be more on the compressive side of the bone. So those generally can be treated by a non-operative sports medicine physician. If it does go past 50% of the width of the bone, that's when you want to refer to your surgical colleagues to consider, having a pin put in. Now, if it's on the tension side, that's a different ball game. I've seen just a handful of these in runners. Typically, it's going to be in your elderly osteopenic or osteoporotic female, and those are typically going to go to surgery. This is one that I think can be overlooked a lot. We published on 11 cases of this a while back. And the reason it can fool you, it's in the area of the lesser trochanter, so just below the femoral neck. And that's right, as you know, where the iliopsoas attaches. And the first time we saw this, our radiologist said, oh, that's just an iliopsoas tendonitis, because you can see here the edema around the tendon as it's attaching there. I was a little suspicious that it was more than that because the athlete was having quite a bit of pain. So I still put the athlete non-weight bearing. And, you know, I got some other radiologists to kind of review it and consult it. And eventually the decision was, no, this is more than that because we see this marrow edema in the bone, not just where the tendon's attaching. And, it really deserves to be called a bone stress injury. And sure enough, that athlete, the first one I took care of with this, although I was cautious with her, she was training for a marathon with the team in training, Leukemia Society. Was going to be over in Anchorage. And so I said, you definitely can't go. Stay on your crutches. But she went with her team anyway. She was cheering on her teammates, but she was still putting more weight on it than she should. She wasn't running, but she came back and she had a full-blown stress fracture in her femoral neck. It extended all the way up. So that really taught me, be careful with these. Treat them in the same way you would a femoral neck stress fracture. As we move down to the femur, now as we get into diaphysis, the shaft, again, these can fool you. You may think, oh, it's just a quad strain. It's kind of hard to localize. But if you do what's called the fulcrum test, you can often recreate their pain. And when you get the imaging, sure enough, it's often in this proximal medial location. And that's right at the origin of the vastus medialis, as well as the insertion of the adductor brevis. So one thought is, maybe some tension from the muscle attachments pulling there. But I think more than that, it's probably just an overload of the bone. In the same way you can get shin splits in the leg, you can also get it in the thigh. And this would just be where you're just going to see that periosteal edema. And this is important to recognize because this is something that you can work through and, have the athlete just modify their activity, maybe try some anti-inflammatories. But it's not a full-blown stress fracture. but at the same time, you don't want to ignore it. As we move down to the leg, I like to divide the injuries to the tibia into three categories. So the most common is the posterior medial cortex. And as we talked about, that's a low risk area. It's on the compressive side of bone. And those will typically heal up just fine. The ones in the proximal tibia will fool you. More often than not, when the resident or fellow first sees these in clinic, they come to present and they say, yeah, I think this athlete has a pes anserine bursitis, because they're going to hurt in that area. Um, but it's pretty unusual to see a pes anserine bursitis, and certainly in runners. Um, so, if you have any inkling that this might be going on, certainly get your imaging, and this is typically what you're going to see. And I put these more in that moderate risk category just because they are going to take longer to heal. You do want to be more careful with these than the ones more distally. And this is the one in the tibia that's high risk. So this is anterior tibial diaphysis. On X-ray, you may see these dreaded black lines, and it's called that just because it has such an ominous prognosis. It's on the tension side of bone. It's in a watershed area. I've seen these in some distance runners, but more often than not, you'll see it in your jumping athletes. And the decision with these, like a lot of these high risk injuries, is, do you wait 3 months, maybe 6 months, see if it heals, or you do something more definitively, and with the idea that you can get back quicker. And this actually was one of our football cornerbacks. He was complaining through the season of tibial pain. He actually had some imaging, and it just showed more of a shin splint kind of picture, but he kept pushing through it. And this was his X-ray at the end of the season. And he was faced with a decision because it was his junior year, season was over. He definitely wanted to play spring ball. Had high hopes of having a great senior season and getting drafted. So he chose to have this rod put in. In his case, it worked out. He was able to go back and he played his senior season. Didn't get drafted, but I think he was happy with the result. The one distance runner that I can recall where got to this point, um, he got really nervous about it, and the surgeon gave him the actual rod, and he was feeling it, and he just was like, geez, if this even takes like 1 second off my time, it's just not worth it. So he waited it out, and it took almost a good year, but eventually it healed. Um, but that's the kind of decision you're often faced with, particularly with your elite athletes. Now, as we go down to the foot, I have to say the injury that has given me more headaches through the years than anything is in the navicular. Um, they present with just this vague midfoot pain. It can be hard to localize. A lot of times, and I've even had full-blown fractures, and the athletes are telling me they barely have any pain at all. These occur in that central watershed region, poor blood supply. The key here is to distinguish, is it a type 1, 2, or 3? And this was developed by a colleague of mine, Amal Saxena. He's a podiatrist here in Palo Alto. And a type 1 just goes through the distal cortex. Type 2 starts to extend into the body, and type 3 goes all the way through. So if it's type 1 injury, you can try to treat that non-operatively. Type 2 and certainly type 3, those are going to go to surgery and have a screw put in. So for the type 1s, you can try a non-weight bearing. You could do a boot. If they're non-compliant, though, definitely put them in a cast, because if they are not compliant and they try and cheat this, I can tell you they are not going to heal. Um, if they are doing well, though, at 6 weeks, you can take off the cast, have them try some partial weight bearing over the next couple weeks, and if they're doing well, then start to gradually progress them back. I wish it was that smooth. Usually it's not. Um, so just keep an eye out for these, because I actually have seen physicians who have uh, basically had their careers derailed because they missed this, and then they were dismissed as team physicians. Again, the operative treatment, certainly for any type 2s or type 3s or non-union, is to put in the screw. And the advantage of that is that your timeline for return to play again is going to be more predictable. The other one that is more often than not going to go for surgery is what we call the Jones fracture. It's at the base of the fifth metatarsal, but it's different than the avulsion fracture you'll have with like a bad ankle sprain where the peroneus brevis avulses off a piece of bone. Here, these are about 1.5 centimeters right at the metaphyseal, metadiaphyseal junction. Again, a watershed area, tension site of bone. So these, once you see this on X-ray, those are tough to treat, and all of our athletes are going to get the screw put in. Certainly, if there's a non-union or it's a chronic injury, it's just that it gives you a much more predictable return to play. So, with the time left, I just want to talk a bit about some of the things we've done to look at prevention of bone stress injuries. Now, what got me interested in this was, and this is like a whole lecture into itself because there's just a lot of other studies and things, but I found this really fascinating. The Israeli military has done a lot of great work in terms of stress fractures because they see so much of it. But they did this study where they looked at their recruits. They looked at those who had a history of playing ball sports. So it was either soccer or basketball, and they had to have played for at least 2 years. And they compared that versus their recruits who had been regular runners for at least 2 years. And what was fascinating is that if they had a history of playing ball sports, they had a significant reduction in developing a future bone stress injury. There was no protection for those who had been runners. So you would have thought that might have built up their bone, but running per se doesn't necessarily lead to increased bone density. And so, it's not really protective of developing future bone stress injury. So I did something similar. We held the USA Track and Field National Championships at Stanford in 2002 and then again in 2023. So I had access to these high-end athletes. And so I basically repeated that same study, but now with these elite runners. And we had 156 elite female and 118 elite male runners. And we asked them a lot of questions, but particularly their previous participation in soccer or basketball. And sure enough, we found that previous participation in ball sports when they were younger was associated with a 50% reduction in developing a bone stress injury. And that was for both males and females. And it was dose dependent. So for every year that they had played ball sports, there was a 13% reduction or 13% decrease incidence of them developing future BSI. However, the females who had any history of menstrual irregularities did not confer that benefit from having played ball sports when they were younger. So this and some other work we did through the years, kind of defining risk factors for stress injuries. But I really wanted to say, I really got tired of treating these, honestly. And I was like, enough's enough already. Like, what can we do to prevent? And this really brought us back to if you think about what causes the female athlete triad or the male triad or red S, it really starts with decreased energy availability. It doesn't even have to be a full-blown eating disorder or disordered eating. Just low energy availability sets that off. And then your estrogen goes down, or it could be testosterone. And then eventually that affects your ability to form healthy bone. And now you start to develop osteopenia or osteoporosis. So the goal of this was to use a nutrition education program focused on increasing their energy availability. And, we really focused on those who were in the moderate or high risk in terms of that triad risk assessment tool. And this was a 7-year study. 3 years we were really piloting, working out the kinks, and then 4 years was really our prospective intervention. And our goal was to put them in a balanced energy state. And we described that as at least 45 kilocalories per kilogram of fat-free mass per day. And we designed low energy availability pretty conservatively. This is what they would use really for athletes or patients with anorexia. So less than 30 kilocalories per kilogram of fat-free mass per day. And by getting them back into that energy state, not only were we able, particularly in the women, to help restore normal menstrual function, uh, we were able to see improvements in bone density, not for all of them, but for a significant proportion. And over time, we were able to see that the incidence of bone stress injury went way down. Now, the interesting thing is we didn't see these findings at UCLA. Um, and there's a lot of reasons why that may have happened. But the bottom line is we think that it's because for a number of reasons at Stanford, we were able to really change the culture to get the athletes to buy into being healthy, to paying attention to healthful nutrition. Um, I mean, it got to the point where one of our women's distance coaches was actually going over recipes and bought them Shane Flanagan's book on healthy, diet. Um, UCLA had some problems. They had coaching changes. They had lost their dietitian. So I think they had problems really establishing that culture. Um, and so that's why, it's one thing to say, oh, we'll just change this, but you really have to look at the full, again, culture and change the athlete's mindset about these injuries. Um, we saw similar results for the men at Stanford. It wasn't as significant, but we did see a decrease compared to our intervention phase. But again, at UCLA, there was no change. So our findings really do suggest that a nutrition intervention that emphasized uh, balancing energy availability, we found that not only did it improve triad risk factors, but it led to decreased incidence of bone stress injury, but particularly in trabecular-rich bone. And again, as you remember what I said before, trabecular-rich bone, such as the pelvis, sacrum, femoral neck, even in the spine, so in the pars injuries we see, that's more trabecular bone. Um, but that bone is more susceptible to a low energy state. So it makes sense that by correcting that, we had a better impact on these trabecular-rich bone stress injuries. So just a few other prevention strategies, just to keep in mind. This was a study looking at female military recruits, and they supplemented them with 2,000 milligrams of calcium and 800 IUs of vitamin D, and found there was a 20% reduction in bone stress injury. And then sleep. This was a really, really cool study that was done in male military recruits. And they divided them into 3 conditions. And then they measured their urinary calcium levels and their bone mineral density just over a 7-day period. So the 3 groups were they had sleep deprivation for 62 hours, or 6 hours of sleeping in a vertical position, or 6 hours sleeping horizontally. And the sleep deprivation, and to a lesser degree, sleeping vertically, had those athletes had significant increase in their urinary calcium excretion, as well as hydroxyproline. And in just 7 days, they had a 5% reduction in their bone mineral density. Now, the good news is when you correct this, it quickly does restore itself. But it tells you it doesn't take that long to see these types of changes in your bone. They also found this was another study that reduction of military basic training marching, as well as requiring at least 6 hours of sleep per night, reduced BSI incidence by 62% compared to a historical cohort. And even if they did develop a bone stress injury, they tended to be lower grade than uh, those who were not following these requirements. So, in summary, sports that involve jumping or multi-directional bone loading, like soccer, basketball, may be beneficial, particularly when done in youth, for optimizing bone health and preventing future bone stress injuries. When present, the triad or red S must be addressed uh, to confer the benefits of weight-bearing exercise and developing healthy bone. Calcium, vitamin D, and proper sleep are critical for optimizing bone health. And proper energy balance, while you're maintaining a high training load, is really key to preventing hormone imbalance, full manifestation of the triad, and your risk of bone stress injury. And using this modified BSI classification score, going over those 4 different categories we discussed, can really help you predict return to play and guide your clinical decision making. So I will stop there. And
Thank you very much, Dr. Fredericson. We do have several questions on the chart. So I'd like to start with the first one. The question was, starting at what age do you consider bone density? And the follow-up question to that is, what about a teenager cross country, age 13 to 15, with back-to-back proximal tibia fracture? How do you handle or manage that?
what was the first question again?
What age do you consider bone density?
You mean when would I get a bone density scan?
And one, that's correct.
Yeah, yeah. So you can justify it. You can typically get insurance to pay for it, which is unfortunately the biggest barrier. Um, if they develop a bone stress injury in a high risk area, if they have triad risk factors, um, and certainly if they have more than one, if they're having multiple bone stress injuries, I've typically been able to get insurance to pay for those. There are some clear criteria. If you go into that consensus paper I talked about from 2014 and the new ones that are coming out, we really outline exactly in more detail when to get the bone density or not. In terms of
And there
what do you do with an athlete who's had 2 proximal tibia? Um, so, couple things. Obviously you want to look for overuse history, right? Um, you want to look for, is there something biomechanical? We know that, for instance, athletes who are more heel strikers tend to put more force that's transmitted to the tibia versus those who are more mid to forefoot strikers. So it could be a gait issue. Um, the other thing is, what now we start to look at metabolic factors. So I always check a vitamin D. That's simple to do. And I'm amazed at how many of our athletes, even our runners and swimmers who are training outside here in California, how many of them are actually low or insufficient with vitamin D. So definitely check that. Um, and that's where too, I think it would justify a full, bone density workup and other labs and such.
We have several questions. We'll go to the second one. The second is, can you discuss or mention your women that take hormonal contraception? If what your thoughts are on that, if that's affected your research, or what are your thoughts on oral contraceptives with bone stress injury?
Yeah, I'm glad you asked that. Because, for years, I think there was this fallacy that if you put women on, you know, contraceptive, that they're protected. But that's not the case. At best, oral contraceptive may keep you from losing more bone, but it doesn't help build up your bone. And so a lot of women think, oh, it doesn't matter. I'm on the pill. I can just do whatever I want. It doesn't matter what my weight is. That's not the case at all. Um, Studies have found, though, that if you really do want to try and improve their bone density, transdermal estrogen can be very helpful. So, that's before you start to think about, would you even do something like a biphosphonate, which you really don't want to do in women who are still of childbearing age, or something like tetraparatide or something like that. But transdermal estrogen would be a nice next step if the reason you were going to put somebody on the oral contraceptive was this idea that it might build up their bone. Um,
The next question is any information on the use of radial or focal shockwave therapy for the treatment of both stress injury?
yeah, yeah, yeah. Great question. So, well, I mean, we use it a lot, right? And for a number of years, we've been using, particularly the focus shockwave for bone is going to be really helpful. I haven't had as much success with the radial. Um, in fact, right now we're doing a huge multi-center study between Stanford, Adam 1040 at Harvard, really Nativ at UCLA, and Marcy Goolsby at Hospital for Special Surgery, and we've got a randomized controlled study to really answer this question. And so anecdotally, I can tell you it works, but now we really want to prove it. So,
So the next question is in terms of bone density also, like what type of injuries warrants getting the bone density in your opinion? I know from my standpoint, sometimes when I see some compression fractures, before you do kyphoplasties or anything, you need to have that bone density done. So is there any type of fractures and injuries that would make you say, I'm going to get the bone density? And when do you get endocrinology involved in that workup? And do you order it before endocrinology consultation or not?
yeah. So at our institution, endocrinology, bone endocrinology, they won't even see them until we have bone density. So we have to get it. So it goes back to that study that was done out of Hospital for Special Surgery in their women's sports clinic a number of years ago. And basically, what they found is any woman who comes in with a stress fracture or bone stress injury in trabecular rich bone, so again, pelvis, sacrum, femoral neck, even calcaneus, or even the pars, um, that justifies an osteoporotic workup. And so that justifies getting the bone density as a start. So you can cite that study, but certainly any woman who comes in with that history, I'm gonna get a bone density test done. Um, Also, just in general, if they're developing multiple injuries, as we mentioned before, I think it justifies it. Um, and yeah, I would say those are the key things, really. Um,
And I think we got one more question. What are your thoughts on speculative role of neocarbon plate shoes contributing to bone stress injury, particularly more proximal injuries? Any comments on newer shoes?
yeah, I know that Dr. 1040 published a case series um, with Dr. Saxena, showing that they were seeing a higher incidence of injuries in the foot with those, even navicular injuries. So it is something to be careful with. Um, yeah, one thing I've seen too is just that there's this, trend really, to go more minimalist, to mimic more of a barefoot running. And in general, I'm all for that. Um, but we for years ran this run safe clinic, and part of that is all the athletes would get a detailed gait evaluation on the treadmill. We put on all the markers, um, and more often than not, we found that. Um, Sorry, what was lost my thought. What was the question again?
About minimalist
Oh,
shoes,
right, yeah,
carbon
yeah,
plate shoes.
yeah. Okay, yeah. So what I was getting at is, sorry, long day. Um, it's amazing, although a lot of people are diving into that too quickly because there's still a lot of people who don't have the foot strength or they don't have the right arch profile to go to a minimalist shoe, right? So for a lot of our athletes who went through the Run Safe program, we actually tell them to get more support because they're still way overpronating. It just now at the same time, we give them exercise to try and strengthen those foot muscles to intrinsically build up your arch so that over time they don't need the orthotic. They can go to more of a minimalist shoe. Um, but that takes a lot of time, and not everybody can always achieve that too. It really just depends on your, particular anatomy of your foot.
I know you mentioned briefly focused shockwave therapy. Do you find those to be more effective in certain type of bone stress injuries? And usually, what's the timeline in which you start those type of treatments?
I've used the focus shockwave for virtually every type of bone stress injury. Even, deep in the pelvis. If you just position them right, you can get in there. And I've even had like just had a high school runner not too long ago who had a pubic rami stress fracture. It wasn't healing. Uh, and she came in for a couple of shockwave treatments and it healed. Um, so I can't think of a bone where I wouldn't use it on. Um, you know, I have to say it's really helped us. And not just for bone stress injuries, but we use it for really a lot of our soft tissue injuries as well. It can really help stimulate the healing process. Now, it's just going to speed it up. It doesn't all of a sudden cure it, and we're hoping to kind of define this better with this randomized study that we're doing. But I think it usually, what I tell the athletes, what I've been seeing is typically it might give you about 2 weeks quicker return to sport, but also it helps ensure that it heals. And even our non-unions, I mean, um, again, another example, one of our football players had a Jones fracture, had the screw put in, but it still wasn't healing. He came in, it took quite a few shockwave treatments, but he did great. He's playing in the NFL now. He's all pro. Um, so I just really can't say enough about shockwave.
And I think I got one last one before you let you go. For bone edema associated with accessory navicular bone, do you treat it the same as navicular bone stress injury? So accessory navicular versus just a navicular bone stress injuries.
Oh no, 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 no. I mean those are I really I mean I might put them down weight bearing for maybe a couple weeks at most, or usually it's partial. It's really just to get them pain free. And but those I'll even sometimes inject those. Because you get that fibrous union there, it can become symptomatic as long as it hasn't fully avulsed that accessory piece. It's really just getting it to settle down and calming down the inflammation.
So on behalf of AMSSM, I really want to thank you, Dr. Fredericson, for an awesome hour on talk on bone stress injury. I would like to thank the participants for the wonderful and inspiring questions as well. Please remember to tune in next week for upper extremity trauma. That's going to be presented by Dr. Craig Rudy. Dr. Fredericson, thank you very much again for the talk.
Great. Thank you. Appreciate you having me today.